Good morning, everyone. Today I will be speaking about COVID-19 and exercise, that is medical aspect, especially focusing on exercise after COVID-19. First of all, I want to thank Indian Society of Lifestyle Medicine for inviting me in this talk, and especially to Dr. Sheila and Dr. Anjali, Dr. Ravi, Dr. Tariq, Dr. Lakshmi, Dr. Salini, and Dr. Anupama. And I am Dr. Hanjabam Barun Sharma, sports and exercise medicine specialist as well as clinical and medical physiologist, and I will be speaking on exercise after COVID-19. Let's begin the talk. So before going into the detail, let's say about, let's focus something about the COVID-19. We already know that COVID-19 has been declared pandemic by WHO. And India, now we are coming up in a phase where little improvement is there. But in 2021, COVID-19 was declared as a leading cause of death in United States, as well as it was also similar in case of India also. But one has to understand that we are fighting currently two pandemic. That is the pandemic of the COVID-19, which was declared since 11 March 2020 by WHO, as well as physical inactivity pandemic since 2012. And physical inactivity, one has to understand, and it is the fourth leading cause of global mortality. And India, especially important for India, because the inactive adult of India is fifth among the South Asian countries, and 12 countries above worldwide. And India has already been known as the diabetes capital, as well as very high prevalence of the hypertension. That's why one has to understand that we are currently fighting the pandemic of the two pandemic, not only COVID-19 but the diabetes. That's why, similar to the case of diabetes, obesity is another concept which we have to understand. Similarly, the real culprit is always, a non-communicable disease where lifestyle medicine, exercise medicine, nutritional medicine has a key important role to play. Like, for example, in this paper, you can see that in 2020, they have reported that, obesity was the leading cause of the, common cause, which is associated with the hospitalization with the COVID-19 in 15 to 64 year old, whereas the type 2 diabetes was in the age group of 50 to 64. And here in this graph you can see beautifully that there is a linear progressive positive relationship between, say, the death death due to COVID-19 and the proportion of the overweight. And hence, in the countries where the overweight, it's adult, more than 50% of these adults overweight, they are associated with 10 times more death rate during the COVID, when the COVID was peak. And that's why this obesity is very much related with the morbidity as well as mortality of COVID-19 associated complication. And here there are lots of published data regarding that. Like, for example, here this paper which was published recently in 2022, here you can see that the SARS-CoV-2 virus infect the mature adipocyte and macrophages, which ultimately lead to the local what you call inflammation, and which will lead to the release of the so many pro-inflammatory cytokines, and which ultimately lead to the overall the causes of the long COVID syndrome, as well as other varied clinical manifestation because of the COVID. And it is very much important when you consider the type of the fat. Like, for example, visceral adipocyte tissue, the COVID-19 is associated with increased pro-inflammatory cytokine, as well as in visceral to the lipolysis inhibited. So depending upon which type of fat which we are the COVID-19, in fact, the clinical manifestation is also different. This is why this is important, because exercise intervention has been known to be very effective for reduction of the visceral adipocytes apart from the nutrition aspect. So this one has to understand. And among other the major culprit is the low cardiorespiratory fitness, as well as the mitochondrial fitness is very much important. And regarding this, we already published one paper recently from our society, saying that lifestyle, obesity, low physical fitness, everything is associated with the complication because of the COVID-19, and they are the real culprit which we have to focus. And like, for example, physical inactivity 2 years before the pandemic was strongly associated with the risk factor, not only as compared to the obesity, smoking, diabetes, hypertension, cardiovascular disease. That is physical inactivity. This is important. And the obesity can increase the infection of COVID-19 by, say, 46%, hospitalization by 113%, ICU the admission 74%, death by 48%. In a similar way, the low physical fitness has been linked, has been considered as a linking mechanism between and COVID-19 and lots of other risk factor of the lifestyle like diabetes, and we have already given different possible mechanism why this is occurring, and this COVID-19 pandemic itself is causing the aggravating worsening the pandemic of the physical inactivity with 30% reduction in physical activity and all these things. So this one has to understand in order to plan an effective physiological intervention in the form of the exercise medicine. So exercise and fitness is extremely important. One has to understand that there may be different type of exercise, whether it is a resistant exercise, whether it's aerobic exercise, or whether it's a sports related, skill related, whether it's a plyometric exercise, whether it's a balance and proprioceptive exercise. This exercise has to be done, and it's extremely important because see, one can see that one MET increase, that is metabolic equivalent for tasks increase, is associated with a 12% increase in survival in men, as well as 13% reduction in also hospitalization. So high cardiorespiratory fitness is extremely important, especially among those who are having comorbidity as well as high risks with COVID-19. And we already published a different mechanism of linking the positive effect of physical activity exercise training on the COVID-19, and this is freely available. I will not go into the detail of this, but the one point which I have to focus is identify the real culprit and focus on that real culprit, not only drugs and surgery, but most importantly physiological intervention in the form of exercise medicine, in the form of nutritional medicine, in the form of sleep improvement. So another lifestyle factor, this is extremely important. So, but one thing is there, because if you want to go ahead with exercise, there are so many challenges associated with the COVID-19, because COVID-19 affect not only the pulmonary system, but lots of extra pulmonary system. It may be neurological, it may be renal, it may be hepatic, gastro, thromboembolic phenomena is so increased. It may be endocrinological problem where insulin sensitivity has been reduced. All these things is important. And like, for example, if we just take the example of a VO2 max, we already know that VO2 max is the aerobic capacity, that is aerobic fitness, and it depends upon, say, lungs, there is a respiratory system, the cardiovascular system, as well as the muscle, and all this system are affected by COVID-19, and that's why you can easily imagine that how much exercise capacity will be reduced because of the COVID-19. But another thing one has to understand, that apart from the acute the infection of the COVID-19, which can go up to 4 weeks, but there are lots of other sequence of the COVID-19, like for example post acute COVID-19, like from 4 to 12 weeks, or post COVID-19 syndrome, which is the continuation of the symptoms after 12 weeks. These are very much important, which are associated, and it is a challenge for for beginning to exercise. But one has to understand that the symptoms of the COVID-19, there are so many symptoms, not only restricted to the neuromuscular system, but also to the cardiovascular, respiratory, and other psychological effect is also very important. But one has to understand that exercise therapy, exercise medicine has an important role to play, not only for rehabilitation, not only for return to play, but also maintenance of the promotion and maintenance of the physical fitness, and the therapy, effective therapy for post-COVID-19 syndrome. This one has to understand. That's why you can say that the acute COVID-19 has an effect on exercise, and exercise has an effect on COVID-19. So the positive effect of exercise one should not neglect, but one has to understand this this balance between the beneficial effect and harmful effect. Like beneficial effect, exercise is extremely important for maintenance and promotion of the metabolic fitness and other type of fitness, or the exercise has been associated with the reduced infection, training, adaptation, which is extremely important in case of the player, or in case of the positive COVID-19 positive player or infected player, exercise can be used as a part of the rehabilitation, in the form of the exercise therapy, in the form of the kinesiotherapy, in the form of the exercise medicine, rehabilitation, as well as return to play. But one has to consider the other side effect also, like for example detraining effect. Detraining is very common because of the COVID-19 restriction, so many restrictions, lockdown and all these things. So detraining may be happen, especially in case of the elite player, or risk of the infection can be there if severe excessive exercise associated risk of infection may be there, or exercise maybe there may be associated say heat exhaustion or post-viral fatigue syndrome when a particular infected person does the exercise, or there may be viral myocarditis also, like other thromboembolic complication may be there in, especially in genetically predisposed person. So one has to understand, sports and exercise medicine specialist has to understand all these things. Clinical physiologist, one has to know all these thing details, the medical aspect, and hence the effect has to be the benefit and risk ratio has to be depending upon that intervention has to be given. Like for example, detraining is absolutely important, otherwise all the beneficial effect which you gain as a as a player, physiological adaptation will be lost if you don't do that particular recommended exercise. For that, one has to understand that at least, for example, for aerobic fitness, one has to do at least 3 times a week, say exercise intensity up to equal to more than 70% of your VO2 max. You have to maintain that particular level if you want to maintain your VO2 max. And one has to understand that this detraining effect, loss of the beneficial effect, is morely, especially in case of the highly skilled and elite player, and especially it may be related with the neuromuscular loss like strength and power. It may be related with the muscular endurance, or it may be related with the flexibility. But one has to understand that the sprint and anaerobic fitness is relatively maintained as compared to say speed and agility or VO2 max. So one has to understand the principle of the tapering also, where you taper, where you decrease the training load, but you maintain that physiological positive adaptation. Like for example, for VO2 for VO2 maintenance of the VO2, your training frequency as well as duration can be reduced, say less than 2 by up to say 2 by 3 times of your previous, and while maintaining that beneficial effect. So tapering can be done, avoiding the detraining effect in case of the COVID-19 restriction the period, and one has to understand this this concept in order to maintain that adaptation. And we already know that the JSFA relationship between the risk of the infection or immune system, this JSFA relationship with the severe exercise intensity. This is the classic JSFA relationship, where the increased infection is there in sedentary as well as overtrain the overtraining or exhaustive training exercise. But one has to understand that recently this JSFA has been predicted to be S-SFA if we consider elite player into this group. That means this JSFA will go on like this, and it will become S-SFA. That means decrease in the infectivity or decrease in disease susceptibility may be there if we include highly elite player. That means the regular moderate to vigorous intensity of the exercise, not exhaustive exercise, is protective as far as this susceptibility is concerned, as well as elite load is also protective to the infection. And this has been published in 2018. And this concept is important because the JSFA is one always think about the JSFA. It can be S-SFA also. Myocarditis extremely important. I will touch a few points on myocarditis. It's a very rare the complication. Only say 5% of the viral infection may lead into the myocarditis, and 50% half they resolve automatically. And the one has to understand that even though it is rare, but up to say 5 to 15 or 20% in sudden cardiac death may be related with the myocarditis. That's why even though it is rare, one has to keep very emphasis on that. And this susceptibility is especially increased when one is doing strenuous high intensity exercise, strenuous exercise, prolonged exercise, or competition, especially in extreme environment. So this one has to understand. So going ahead with some of the athlete and myocarditis, as I already focused, that is up to 20 to 25% of sudden cardiac death in athlete may be because of the say acute or subacute myocarditis and perimyocarditis. But one thing to focus is very important, that the mild earlier stage of it may be myocarditis, may pericarditis, may mimic the overtraining syndrome, which is so common in case of the elite player also. So you have to differentiate whether a particular player is going into the overtraining syndrome, or whether indeed he or she is having the initial symptoms of the say myocarditis. So depending upon that, you have to understand a certain key point. Like for example, impaired exercise capacity, impaired muscle strength may be there, which is similar to the overtraining syndrome. There may be muscle soreness, there may be general decrease in drive discomfort may be there, or increased exercise heart rate, or heart rate may be there. So and another point is the chest pain may be there on say lying down on the left side. That is if the pericardium is involved. So one has to understand all this thing, and depending upon that, one has to go ahead with the require what you call the investigation, especially ECG and other, which I will be talking later on. And that's why if a particular person, if a particular athlete has been diagnosed as with having myocarditis, then you have to be very careful. At least say 6 months of sports training should not be done. Exhaustive exercise or sports competition should not be done in case of the myocarditis. In case of pericarditis, at least 3 months. And rule of thumb is very important. At least the rule of thumb says that 1 week, at least say 3 to 5 or 7 to 10 days, 1 week of no symptoms should be there. If you want to give exercise which should be very short and very mild, the exercise training can be given, and especially before increasing the intensity, you have to focus on more on duration. Then slowly it has to be increased. And resistant training, we generally avoid the resistant training until all the symptoms are resolved. But the most important point is 6 and 3 months, which one has to understand. And this is just the the assessment, the different algorithm has been prescribed. But the point which I have focus is depending upon your echocardiography finding, you have to do the cardiac MRI. This is very important in order to see whether there is fibrosis is there or not. And depending upon the finding of the late gadolinium enhancement, you can re-evaluate that particular person after 3 to 6 months or 6 months, and whether the presence or absence of the fibrosis, depending upon how symptomatic a person is, how much fibrosis is present, what is the risk of the ventricular fibrillation, one has to make the particular person eligible, or treatment has to be done as part of the current guideline. And this has been given by different recommendation, like European Society of the Preventive Cardiology and different other society has given. Similarly, our society, that is ISSEM, Indian Society of Sports and Exercise Medicine, we have recently published this consensus statement regarding what to go about it. Like for example, risk stratification, like I have already focused. Physical inactivity, poor cardiorespiratory fitness, apart from the obesity, can be used as a risk stratification in COVID-19 because they are associated with the COVID-19 complication. This one has to understand, and one has to understand how much exercise target has to be done. Because see, physical distancing, social distancing doesn't mean that you have to distance yourself from physical activity. You have to do the physical activity, and that physical activity had to be at least 150 to 300 minutes per minute of moderate to vigorous exercise. If you are doing vigorous aerobic exercise, then at least 75 minutes you can do, or you can target up to 150 minutes. And strength training, it is always advisable to do at least 2 days of strength training per week. This is absolutely important. And one has to understand that if there is any activity related alteration which you cannot explain in changes in perceived rating of perceived to exertion, that is RPE, then it may indicate COVID-19, especially in case of the player. This is important for the coaches and sports medicine doctor. And you should have that very high suspicion index. And but just by noting that if unexpected, unsuspected, unexplained change in rating of perceived exertion may lead that the patient may be having, the player may be having COVID-19 infection. That's why early detection and treatment, one has to understand. Rehabilitation has to be done, absolutely important. Exercise medicine, exercise therapy is an integral important part of the rehabilitation, which has to be multidisciplinary, which has to be phase wise, which has to be symptom lead, and which you have to begin from early mobilization, beginning from the passive to the active movement, from light exercise to moderate exercise. And for the players, return to activity is also important. Like for example, if a player is a COVID-19 positive who is asymptomatic in this case, then he should restrain from doing any kind of the intense high intense activity for at least 2 weeks. And no sports participation should be allowed for asymptomatic players. And if a particular person is symptomatic, but there is no pneumonia or there is no myocarditis, then at least 2 to 4 weeks has to be given before starting any kind of the moderate to intense exercise. In case of say pneumonia, then you have to wait for at least 4 weeks. For pericarditis, at least 3 months, and for myocarditis, at least 6 months. So these are the guidelines which we have decided based upon different published literature, and this can act as a guide, a simple guide. Individuality you have to apply in your particular practice. For a recovered player, in order to begin the exercise training, one has to be no symptom. Symptom should not be there for at least 7 to 10 days, and the initial at least 10 days should have passed from the initial symptom onset. This is important. And return to play should be done with a minimum exertion, or say for mild to mild exercise up to 2 weeks. Then after that, you can slowly increase the intensity and duration, so that you may reach the pre-COVID level in at least 4 to 5 weeks. This is important, and one has to know that medical evaluation and relevant cardiac, it may be cardiac, it may be pulmonary, it may be ergometry, CPET, that is cardiopulmonary exercise testing, as well as biochemical and other investigation is very important, and it has to be done, say if required, it has to be done from 24-hour to 24-hour basis. This is also important. One has to keep a very high suspicion index. And apart from that, different clinical physiological intervention in the form of exercise, in the form of lifestyle, in the form of nutrition, in the form of sleep, different things are also given our society, which one can read easily in this paper. And similarly, we have also given certain guidelines for the resumption to swimming post COVID-19. It was also published from our society based upon this guideline. Not only our society, different different published the articles are also there regarding return to play. Like for example, here you can see that if a particular the player or a particular player is not having any kind of sign and symptoms related to the COVID, which may be cough, tachycardia, extreme fatigue, dyspnea, or any other thing, then you can do the routine that PP, that is pre participation physical examination. And if there is no problem is there, then in fact, you may not do further cardiac or respiratory investigation, and you can prescribe the particular player to go into the return to training from progressive return to training, starting from mild to moderate. This is important. If a particular player has recovered from COVID-19, it has to be just like that I have already spoken. He or she has to be symptom free for at least 7 days, 1 week, and no sooner than 10 days is extremely important. You have to do ECG, because see, your this thing depends upon the three system. You have to target three, that cardiac system, respiratory system, biochemical parameter, as well as other parameter which may be relevant. Like for example, cardiac system, I will focus on the 12 lead ECG or echocardiogram. If abnormal result is there, then you have to do cardiac MRI. You do cardiac with or without lead gadolinium enhancement test, or 24-hour ECG Holter testing has to be done. Like for example, what you call high sensitivity cardiac troponin T can be done as a part of the biochemical test, or CPET, that is the cardiopulmonary exercise testing, ergometry testing has to be done. And depending upon whether the symptom, whether results are normal or not, you can decide on that whether you want, in case of the abnormal, whether you want to proceed with the the current guideline-based treatment for myocarditis or any other related symptoms in the player, or he may be allowed for a gradual return in the rehabilitation plan. This is important. Similarly, for the players who have not recovered, from the COVID-19, similarly, one has to do again extensive investigation has to be done related with the cardiac, related with the respiratory system and biochemical. Like for example, cardiac, you have to do ECG and cardiac MRI in that case. If the symptom is there, if the some symptoms is in fact present, equal to more than 2 weeks, that is 14 days, then you have to do at cardiac MRI, no other choice. And lungs, chest X-ray, simply chest X-ray, and what do you call lung function test, one can do. And biochemical D-dimer has to be added, C-reactive, protein, CRP, C-reactive protein, high sensitive C-reactive protein, high sensitive cardiac troponin T. All this investigation has to be done, and depending upon whether a particular symptom is abnormal or normal, like for example, if there is abnormal in D-dimer, C-reactive protein, or other biochemical testing, then you can go ahead for CPET, that is cardiopulmonary exercise testing, and 24-hour Holter. Depending upon whether the result is normal or not, you can further go ahead with the treatment plan or into the rehabilitation, going to return to play. This is important for a hospitalized patient. Absolute care has to be given. Cardiac MRI one has to do. Absolutely, you have to emphasis on cardiac MRI, not only echo. Cardiac MRI is important in order to rule out the possibility of the fibrosis, the possibility of whether the particular person will have ventricular fibrillation or not, which are associated with the sudden cardiac death in players. This is important. And this is my last slide, and I will be focusing on exercise and marks, because these are the common questions which people ask, like anything, whether we should use marks or not. The rule of thumb is always, if you are doing exercise in a safe environment, in COVID, appropriate behavior, where there is absence of any other the person around, then it is always advisable not to wear masks, especially in moderate to intense exercise or intense exercise. But if you have to wear masks in anyhow, then you can wear masks if you are provided, if your system is normal, if you are physiological normal, because the physiological system, your physiological system, has the ability to adjust to it. Like for example, this paper was published in 2020, where they have the masks, surgical masks, cloth masks, with they have not seen with the N95 masks. But here you can see that the time to exhaustion was there was no statistical significant difference was there, whether you wear masks or not. And you can see that the different physiological parameter, like for example blood oxygenation saturation, tissue saturation, rating of perceived exertion, heart rate, and all these things, they are relatively statistically not similar, although you can see that the heart rate is little bit higher in case of the cloth masks as compared to the surgical masks. This is also important. Similarly, this paper, which was published in 2021, they have highlighted in healthy adult, short-term moderate to strenuous aerobic physical activity can be done by using masks. Whether it is a surgical mask or whether it is N95, you can do it. It is a feasible 7 associated with a very minor alteration in physiological parameter, which may not be relevant as compared to your performance parameter. But again, the rule of thumb is always there. If you are doing in a safe environment, then there is no need of masks, especially if you are doing high intensity exercise. This one has to understand. And in market also, different masks are available, which are also known as hypoxic masks. These are totally useless. You don't have to use this such type of masks, because these masks do not mimic the environment for hypoxic environment. That is, you will not get all the benefit of high altitude training by just wearing this masks and restricting your breathing. In fact, it will increase your stress and what you call rating of perceived exertion. You will be feeling more exertion, and hence your repetition to failure will be decreased. That means you will not be able to do much exercise, resistance exercise. This has been published. So one has to focus on whether to use exercise marks or not. And the rule of thumb is always, in a safe environment, don't use marks, especially for high intensity. But if you have to use, no problem. There are so many papers which has been published saying that in healthy individual, trained individual, in adapted individual, especially for moderate to strenuous aerobic exercise for short duration, marks is, even if N95, there is no problem. So this one has to understand. So I have come to the conclusion of my talk, and thank you very much for giving this opportunity. And the most important point which I want to focus is always, don't focus always on the different medical therapeutic intervention and just forgetting the physiological intervention. No, physiological intervention has to be first, because positive activity, positive lifestyle, exercise and physical activity leads to the positive physiological adaptation, which is essential not only for the sports performance but also for the exercise performance and and also the human performance, which is associated with the decreased infection as well as decreased morbidity and mortality associated with the COVID-19. So this is very important. I have to rush like anything because limited time was there. This is a very big talk, so only 20 minutes was there, so I have to rush. So if there is any question, please put forward. Thank you very much.